And in talking about numbers in our industry, I have talked to you about the Benchmarking Alliance, talked to you about the fact that as we originally met together as emergency department leaders, and we talked about getting numbers together, the first realization is there's no definition for any of those numbers. What is a pediatric patient in your emergency department? How many of you have a definition of pediatric that says 12 and under? 14 and under, so a couple. 16 and under, a couple. 18 and under. How many of you don't know? Okay, so when we talk about peds, patients, and percent visitation to the emergency department, do we have a reliable statistic to compare? That was version 1. Version 2 was, by the way, what's an ED patient? Okay, as we asked everybody, well, an ED patient, some places they excluded all patients who were treated but never made it to triage. In some places, they included all the nighttime L&D patients who came in because they registered through the emergency department on their way up to L&D. And so something as simple as what's a pediatric patient and how many patients did you see last week or yesterday or last year was very complicated. And so in order to get data and get reproducible data and get good comparative data, we had to go back and do definitions. So that has been one of the functions of the Emergency Department Benchmarking Alliance. And I'll move very quickly into talking about the specifics of numbers and trending data. All right, benchmarking, again, is humble enough to admit that somebody's doing something better and wise enough to know how to match or surpass them at it. And a big ED in 1994 was 40,000 volume and up. And so we had leaders of big emergency departments. And in a very unique way, during that time, we got doctors and nurses and administrators to all sit down in a room together. Because in the past, the ED physicians went one place, the ED nurses went another place, and the administrators went a third. And then collect data, but data led us to definitions, and definitions led us to the Performance Summit that took place in 2006. The Benchmarking Alliance is now this group of emergency department or clusters of emergency department, and we collect data now for 170 sites with about 7 million patient visits for 2008. When we needed data, we wanted to know what existed, what were trends, and what trends then would be reproducible into future planning. What did you really need to manage an emergency department? And at the end of this presentation are the 20 numbers needed to manage your ED. And then where are best practices? What are hospitals that have found better ways to manage certain pieces or all of the pieces of the experience for the patients and the staff? There's an industry gap in that we don't have really good data sources, and when the federal government comes looking for numbers, both ENA and ACEP are not able to produce those numbers for a variety of reasons. One of them really is antitrust, and there are a couple of other operational reasons. There's no journals for us to publish our numbers in, and some of particularly our nurse leaders were frustrated. They had done some good little operational studies to look at some element of the emergency department visit and what they did better. And when they went to go publish their studies, of course, Annals of Emergency Medicine is not interested in those types of studies, and there's no little journals that do sharing of information like that. Street legends abound in terms of our industry. Rick and Sherry both talked about street legends, and I'm going to identify some for you here. And then there was no way to identify by numbers what are best practices and for us to be able to guide our members or other people to it. So our solutions were to produce a data source. Don't put ACEP and ENA in untenable positions or positions that cause the federal government to take a look at them. Find places to publish, which we have not done yet. Call together groups and produce definitions, which took place in 2006, and hopefully under Sherry's leadership will take place again next fall. We'll do, or next winter, a couple months from now, when we will do the second summit. We have to counteract street legends, and one of the ones that we took on very early and will be laughable to you, one of the big insurance companies in this country had looked at literature and decided that any emergency department that admitted over 15% of its patients was a bad ED and was going to be punished. And they were going to be punished with withdrawing quality points. And the quality points then were used to calculate the formula for paying them for hospital admissions. So we got that information through one of our members who said the hospital administrator to come down kind of in a panic and said, what's the ED admission rate? It's 27% in our hospital, sir. And the administrator said, oh my God, that's going to result in a $2 or $3 million loss from this one insurer, because here's their definition for a quality hospital, and a quality hospital has an admission rate from the ED under 15%. The ED director appropriately told the CEO, said the only way I can get down to a 15% admission rate is if I go grab people off the street and sign them in as ED patients, because, sir, we see really sick patients here, and a good number of them need to be admitted. As a matter of fact, 15% probably gets us to our ICU admission rate. You know, they see very ill patients. So then the director queries the rest of the benchmarking alliance, says, what's your admission rate? Well, within the ED benchmarking members, a whole bunch of them were over 15%. Some of them were pushing 30%. And so as a group, we then replied to this insurer, give us data sources and reasons why you would want to define a high quality ED. They came back with this wimpy statement about, well, in our experience, we have found that really lazy emergency department doctors just think that everybody needs to be admitted upstairs, and therefore our quality definition is 15%. So we went wrestling on the mat with them, actually visited their offices, took the data from the Benchmarking Alliance and some other hospitals we recruited in to get their data, and then forced them to back off. So a success story, and frankly, all of you may have benefited from that and you didn't even know it. But you got to go wrestling with people who produce false benchmarks. And the people who are paying the bills, as we're going to talk about, are really famous for doing that. All right. Another encounter that we had during this was with Carlos Camargo from Boston. And he had produced a system called MNet out of the Harvard system, and they had been going around counting emergency departments and identifying volumes. They defined about 4,800 American emergency departments and found that there were a large number of them, particularly in the West, that were seeing under a patient per hour for the year, so under 8,760 patients. And so then they focus some of their look on the EDs that saw 8,760 patients or more per year, and found 3,327 of them. And when you look at the average volume seen in those emergency departments, it was 33,000. So they have a website, MNet, and they produce a map, and you can look in the state and click looking for emergency departments. This is their distribution of volumes by size, and you get some idea that we have a large number of emergency departments that have micro volumes, okay? And then we keep moving this further and further to the right, getting into larger and larger emergency departments. They also compared their numbers to the AHA numbers. AHA has a voluntary membership, okay? And not all hospitals in the United States belong to the AHA, much less looking at other international emergency departments. And the CDC data only come from AHA members. And so there's a gap, again, in our data when it comes to knowing how many patient visits there are in the emergency department and then being able to characterize them. Okay, you're going to begin to see green boxes here, okay? And I'm going to call those street legend alerts, okay? And warn you that there's some pieces of street legend that are out there. Rick?
I think you have to just click it again.
I do? Sorry. Okay. My bad. Thank you. Street legend alert, our payer mix, and has our payer mix deteriorated significantly over recent years? Hasn't recently. And then, oh, by the way, the street legend was roaring around late this summer that emergency departments were seeing a worsening of payer mix related to the economy. So we did a quick query of our members to see what our volume and what our payer mix looks like. And so far, and this is probably just a time-related element, but there's been no deterioration in payer mix from any of the members of the Benchmarking Alliance. And it probably will change this winter when COBRA benefits begin to run out for many of the people who were laid off. And usually COBRA benefits extend out about 18 months. And so we may see a mix change But you recognize here our number one payer continues to be commercial insurers, then Medicaid, then Medicare, then self-funded, and then a small and shrinking number of ED patients are workers' comp, another manifestation of good injury prevention programs. Another look at the industry, which we haven't done. Everybody said, oh, we're just small potatoes, right? And nobody really needs to think about the emergency department. Well, the reality, when you begin to look at the number of EDs in the country and how they're staffed, there are about 36,000 full-time equivalent physicians who probably work in this country based on both ACEP numbers, and then if you go through and count the number of emergency physicians needed to staff that many departments, 3,600, and there are probably another 10,000 that do emergency medicine on a part-time basis. Emergency nurses, 114,000. ED nurses and techs, 114,000. And back office, the Bobs of the world, another 36,000. And so we're looking at about 300,000 people employed in the world of emergency departments. What is our financial impact? Well, the big numbers are EMS has about 16.8 million encounters per year. ED facility, the old number that I used for calculation was 117 million who didn't walk out before treatment was complete. That number for this year, I have no doubt, is about 130 million. And based on a revenue prediction with Rick's numbers, about $23 billion is spent on emergency department services. Ancillary testing, another 23 billion, and emergency physicians, about 11 billion. So on this page, and I added EMS as well, but the ED alone is about a $57 billion direct revenue industry. And then if we get to the admit charges and then the contribution to overhead, and I used $5,000 contribution to overhead per admitted patient, we have a revenue, a financial implication around $117 billion for our industry. So a 300,000 person industry in this country with influence over $117 billion. We are in fact a major industry in terms of finances and in terms of being part of the health system. All right, here's Americans. We're voting with our feet. People like you and want to come and see you and value your opinion or value the convenience of being able to see you when they perceive that they have an urgent need. I believe this year we will be over 140 million visits, and my guess is that for 2010 our volume will be down. Most of you saw increased volumes this year based on H1N1. We were volume neutral through March. In April we kicked, and for October as a group we were up 7.4% year to year. Okay, and I think probably that reflects what's going on nationally. Are anybody's numbers really different than that? Anybody seen down volume this year to date? Have most people seen at least a 5% increase in volume? Okay, let's do by hands. How many do you think 2 or 3%? Our average, so a couple. How many think about 5%? A lot. How many of you think 7 or 8%? Okay, a couple. And how many 10% or more? A couple. All right, and those really reflect, I think, what's going on nationwide. That we've had a really big year. My bet is that next year is down. I will bet that for 2 reasons. Number one, hopefully H1N1 will be done. Okay, and people will need a little respite from public health. The second thing is my real significant feeling in the cities I've worked in is that the population who was living in our cities and working to build our houses and buildings and all that kind of stuff that came in from overseas, a lot of those people are no longer there. They're no longer in this country. And where did they go get their care, for their health care? They all came to the EDs. And so I think there's a lot less people in this country that are seeking emergency care, and it's reflected in decreasing volumes in many of our emergency departments. Now, we've more than made up for that this year because of the flu, but I think next year we'll begin to see that volume implication. All right, this, for you, those of you this morning, you're going to see this for the 3rd time, but when we prevent early premature death and injuries, we have an older population. And this gets reflected in one more area, I got to tell you. I go to trauma M&Ms, and they sound like senior care rounds. It's 60-year-olds falling off their roof. and it's 70-year-olds driving, and the driver goes into VTAC and they wipe out the car. And it's 80-year-olds who are changing their light bulbs and fall and fracture their hips and bang their heads. And all of them are on thinners. And their mortality rate is going up. Now, you tell me, an 80-year-old who falls and bangs their head changing a light bulb, or a 16-year-old who wraps themselves around a tree, who's got a better chance of dying? The 80-year-old. And so the trauma surgeons in our area were looking at, on a case mix basis, increasing death rates amongst trauma patients. And they thought, oh my God, somebody's going to lay us out because we have more people who are dying of traumatic injuries, and our percentage of death is increasing. And then we looked at their data, and the 60-plus-year-old trauma population is very large. It's a very significant number. And those people, no matter how, fall off a step stool, it is a potentially fatal event for many of those people, particularly on thinners, and they bang their head. And or dislocated, fractured hip, and all the other things that typically are low mortality amongst the general population, but amongst the seniors. So we had to go to the trauma people and say, there's probably a blip beginning to form in your numbers, and it's because we've aged the senior population. In the community I lived in Ohio, we had 5,000 senior care beds in the township. What do you think our trauma population looked like? It was all elderly. We have a few wrecks amongst young people every once in a while, no real penetrating trauma. But the 80-year-olds driving out at noontime would either wipe themselves out or be unconscious, seizing, stroking in VFib as they blew an intersection and wipe out a family or wipe out 4 of them in a car. Or their friends coming to visit them at noon would have an acute medical event. I spent a disproportionate amount of my time talking about geriatric trauma and about searching for the medical cause of the trauma event. And that was the reality of our township, 5,000 senior beds, and we had 5,000 plus all of their friends and people coming to visit them as our trauma population. We really, really looked like senior care when it came to M&M rounds. All right, cardiac arrest, fall, and success rate in resuscitation, and we add more people to the population, older and sicker. Okay, overall, over many years, our injury visits to the ED are going down. Anybody not have that experience? The senior members of our contingent here, I used to love to go in the ED in summers and see all kind of injuries, and now all summer long it's medical stuff. In particular, our transportation and industrial injuries have seen significant reductions amongst the ED population. Our population is growing with the mental health, and particularly where we've had failed community mental health, our numbers seen in the emergency department and their lengths of stay. And then as Sherry was pointing out, you got to take those people out of your length of stay because they're there by definition based on a lack of a community resource, which is mental health resources. And you guys know that you don't control the movement of those patients. It has nothing to do with you. And as a matter of fact, the mental health population, I say they're the only people I cannot treat the way that I want to treat. And I cannot treat them at all in certain circumstances because mental health says if they ain't acting out when I come in, I can't admit them. So a screaming psychotic patient comes in, threatening, etc. I have to let them act out. I have to go in and collect what, guys? They have to have a drug screen, don't they? And they have to have blood work done. And then the social service tech from your community mental health, if you still have that, comes waltzing in and says, oh, doctor, the potassium is 3.4. I can't see that patient. The drug screen isn't done, doctor? I can't see that patient. I don't guide what they can do. Doctor, when you have a potassium level over 3.5, since that's the lower limit of normal, when it's over 3.5, I will have one of the techs on the later shift come in to see that patient. Is that right, guys? Yeah, and is there any other group of patients who you can't treat in your emergency department who come in? And is there any other group who somebody else guides their care, particularly a non-medical person who says their potassium isn't high enough, I'm not seeing them. Obviously, they're medically unstable. And you don't control a $500 drug screen. They tell you that you have to do the $500 drug screen in alcohol, so you got to wrestle with the psychotic patient. You can't treat them. You have to let them sit in a room and scream until the results are back. You call a tech at their mercy. You're genuflecting there. Please, can you come and see the patient? They come in whenever they want. If the patient isn't screaming, they say, I can't evaluate this patient. So if you Haldol or Ativan them and take them down, they're not going to evaluate them, they're not going to admit them, and they're staying in your ED for an unknown period of time. I urge you to take those people out of your time statistics. All right, numbers. We went over these numbers. 405 for the last year per 1,000 population, and it's heavy amongst the seniors. We're seeing less people who are dead or dying. We're intubating less people, but we're doing a few more interventions much more commonly. We do less wound care and less orthopedic care relative to the number of patients that we see. But we see more self-inflicted wounds, and we see more nosebleeds. That's ENT care. And there are nosebleeds amongst the elderly and cold weather circumstances on thinners, and those are harder patients to manage. We x-ray about the same relative to our population, but we use much more advanced imaging, and we use many more cardiac enzymes and EKGs. EMS arrivals, street lore, all those non-sick patients coming in by ambulance using it as a taxi cab, not true in the systems that I work in. As a matter of fact, the percentage of EMS arrivals that get admitted to the hospital have stayed flat over about 20 years, between 35 and 40% admission rates if you come in on an ambulance. EMS transports about 30 patients per minute in this country. The majority of them are for heart disease, chest pain or ACS presentation, short of breath. Blunt injury may be the results of motor vehicle accidents, syncope and seizures. So a street legend alert here is make sure when somebody comes in to talk about EMS, you have the statistics and you're able to use this stuff to talk about it. Time of day, looking at a few emergency departments, adding a few more EDs. We see low lows in the middle of the night. Everybody begins to bolus up at about 8, 9, and 10 a.m. It goes on season after season, day after day, week after week. We don't staff for it, and we don't make the day shift turn the beds. That's what we should do. If we were efficient managers, we'd say anybody who arrives between 8 a.m. and 6 p.m., doctors and nurses, you got 90 minutes to make a decision, and then they got to be moving because the bed has to be available for the next bolus of patients and prepared for evening arrivals. We should staff, we should plan, and we should process for effective movement of patients during the daytime hours. For people who arrive in general after 10 p.m., you got beds and you got staff. We have run across risk management problems discharging people at 2 and 3 and 4 a.m. I think probably you have too. And the most famous of this was we discharged a lady who wanted to go home after she passed her kidney stone at 2 a.m., but she got to the home, didn't have her keys. She tried to climb in through a window, got caught in the window, hung out the window until she died in the cold. And of course, they just crucified us. How can we discharge somebody who'd been given pain medicine and all that at 2 a.m. and we sent her home and she didn't have keys to get in, and she tries to climb in through the window and hangs until she dies in the cold in the middle of the night? How can you do that? And in the middle of the night, frequently we hold people, and we hold them there not for medical hold, but because it's simply an unsafe environment to send them out at 2 and 3 and 4 in the morning. So kidney stones that come in the middle of the night or late in the evening hours, holdovers are fine. You pass that information on to day shift the next day. When the person wakes up, you let them go home. Peds heavy, emergency departments, peds heavy, lower lows in the middle of the night and more peaks in the evening hours. And then I show this blue hospital here because you can train your community that if you are going to open your peds track at 11 a.m., they are going to show up at 11 a.m. with their child. And so you can train your community very, very quickly when you want to open your peds track. They will come. Day of the week. What's the bad day of the week in your institution? Are most people on the Monday schedule? Monday's the worst day. Tuesday's the next worst day because it's left over from Monday. Thursday's the best day in the emergency department with both low acuity and low volume. And so you can do a multiplier as well of volume times acuity. And typically it comes out to Thursday and Friday are your nicest day. When does the street lore say the bad times in the emergency department are? Weekends. It says weekends. And if anybody offers to come in to visit you on Saturday nights or Friday nights, thinking you're full of all those drunk patients and all that kind of stuff, don't let them come in. Don't let them come in. If you have somebody who wants to come and see the ED, have them come in at Monday at noon and see what the ED volume and the ED challenges really are. It's lots of sick patients, ventilators in the hallways, difficult times for staffing and getting admissions there. Don't fulfill anybody's expectations. They're going to come in and see an ED full of drunk people riding in on the ambulance as a taxi cab. We got to break up those street legends. You should produce a diagram that looks like this, that says EMS, walk-ins. There's the numbers: 80 per thousand run in by EMS, 325 per thousand walk-in, produces an overall utilization of 405. Our walk-in rate is X percent of what we see in the ED. ROI by EMS is X percent of the patients we see. And then outflow, we transfer a certain portion, we admit a certain portion, we treat and release a certain portion. Admissions going up, another credit to you for what you have done. The 20,000 volume increments resulted in us breaking up the ED volumes and cohorts by the definitions at the Performance Measure Summit into very large EDs, which see over 60,000 per year or over 165 patients per day. Large community hospitals, 40 to 60, medium 20 to 40, small community under 20. Referral centers do both trauma and transplant services. And again, if you're doing those services in your hospital, are you going to see a sicker population in the ED? Heck yes. Those are going to be really sick people coming in. So, 2008 EDBA data set, 170 emergency departments, seeing about 7 million patients. Here's the breakout, okay? Pediatric hospitals, low percentage admission rates, low EMS arrival, and even when they arrive by EMS, a low percentage admission. Median lengths of stay, just over 2 hours. For patients treated and released at about 2 hours. And for admissions, and this admission rate has less effect because we have a lower percentage admission rate. Left before treatment complete, 1.6%. Low use of EKGs and x-rays. I don't have enough data to do the CTs per 100. Don't have enough data to do percentage of hospital admissions. And the door-to-doc time about 29 minutes as a median time. Everybody okay with that? Now let's go through all of the other emergency departments, starting in the small community EDs. So under 20,000 volume, the least sick, the most pediatric, the least EMS arrival, the shortest processing times, the least use of diagnostic equipment. Everybody okay with that? As you progress up through the 20,000 volume bands, progressively the patients, fewer pediatric patients in general, although any ED may have the PEDS track, may serve as the PEDS hospital in a 2 or 3 hospital community. You have variations. But with pediatrics comes low acuity and changes the volumes. Piece 2, admission rate. As you go from low volume, remember what the number was I used? That Anthem was going to use as a cutoff. What was the number? 15%. As we go, even in medium community hospitals, it's above 15%, 19%, 20%, 26%. Okay, so we see sick patients who get admitted to the hospital despite strict admission criteria. Arrival by EMS, lower, higher, 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 higher. Admit rates, really not very much different. It runs between 35 and 45%. So the street legend of EMS arrivals of non-sick patients, really not there. And if you want to build your market, of course you build it with EMS patients. They both get admitted and they spread good word about your hospital through the community. Lengths of stay. Now, if you're comparing lengths of stay, we go from 128, 177, 199, 235, 291. As you go up through the complexities of the patients, the lengths of time, what do you think the trending is on those numbers? Are we doing better or are we doing worse? We're doing worse. And it's a manifestation of two things. Some EDs are working very hard on the patients who are treated and released and have begun to work some of those numbers down a little bit. But where the deterioration has occurred is in the admitted patients. And these are very high numbers. And imagine the median patient in a referral center emergency department is in the ED almost 8 hours, 7.5 hours. Those are lengthy times. And if you lengthen these times, it drags this number up. And that, frankly, has been what's happening in a lot of our emergency departments. As we increase the stay, and increase even the stay for the patients treated and released, our numbers here are going up. And within each of these bands, there seems to be a tolerance level. In small community EDs, if your processing time goes over 120 minutes, in general, the walkout rate goes sky high, okay? In the referral centers, people are tolerating longer stays and don't walk away at the same frequency. And so our left before treatment rates are going up, and the CDC data has been missing this so far. And particularly in the busiest emergency departments, it's gotten to a very high level, probably a concerning level. Yes, sir?
Can you clarify what the LBC?
Left before treatment complete.
I mean, just some of us use left LBC, and they both in
All of those things combined. We had a hard definitional problem because some people talked about AMAs, some people talked about left before triage, left before medical screening examination, left before. So we globbed everybody together and said, anybody who left before they were supposed to.
But an AMA, where you're done, you have every single piece of information, and you then recommend admission, but they want to go feed their cat. That's not left prior to completion of treatment.
It isn't. And in general, that is a legal event, a risk management event, and not a service event.
So how would you classify?
There's a small number of those. And in general, those are classified a different way. In all of the EDs I work in, those types of AMAs are not reportable as a service problem. It's reportable as a risk management event.
I agree, but at the bottom of the chart, somebody checks out the AMA box, and that's how it goes into the
Yep.
right?
Yeah, and there may be a small number of those who are in there. Let me keep going. EKGs per 100, is this number increasing or decreasing? Boom, right straight through the ceiling. The number of plain x-rays done, going up or down? Staying the same or going down? We've maxed out on the plain films that we've used. But the CT use per 100, do you see these numbers? Now, the CDC says it's about 14 or 15 from 2006. Why is the data different from the CDC? They over-select patients from smaller emergency departments, from non-referral EDs, and they use a number that says the percent of patients who receive scans. We went up to the number of images done per 100 patients seen, okay? And so somebody who gets pan scanned in our EDs gets credit for 4 or 5 or something. In addition, we say all of those scans done divided by the number of patients seen is an accurate number in talking about the use of a resource. And so that is how we have come to different numbers, because the radiologists, when they come to scrutinize you and throw a paper on your desk to say you're using 800 scans per 100 patients seen, they're using the rote number, number one. And number two, they don't look at percentage of patients who have it, because they don't know what percentage of patients they're seeing. They don't know your ED numbers. So just so you realize why that number is different than the CDC number, and it's almost double it. And in our big referral hospitals now, we are seeing, I'm sorry, I'm over here. We are seeing some EDs that do more CT scans than plain images. And so we've begun to reverse that. Percent of hospital admissions. In the smaller hospitals, they have the greatest percentage of patients seen and admitted, as opposed to direct admits coming in. Why is that? Well, in the smallest communities, the pathway into the inpatient bed is through the ED. Essentially, in many small emergency departments, all of the patients who are going to arrive upstairs come in through the emergency department. And so some of our EDs are at 85 and 90%. And then the door-to-doc, and in the referral centers, obviously, there's a pathway that goes helicopter from somebody's ICU into your rooftop, into ICU or into the OR or into the cath lab, that results in a lot more admissions. Door-to-doc, these numbers are generally beginning to decrease, and it's because of front-end flow process improvements and other efforts that you have made. So the ED data set, for 2009, we're going to double the size of this. We've had another large hospital system come in, so we'll have about 300 emergency departments. We will throw their numbers in and have even more reliable data for you to compare to. If any of you want to send your data in and do comparisons here, more than welcome the addition of that. And there's trending now over 5 years, so we have each of these for each of the volume bands that are going over time. Yes, sir.
From a service perspective, just out of curiosity, why did they decide to look at each CT scan study
Yeah, the real reason was that's what radiology comes down to you with. So when we talk to the ED leaders, what radiology and the radiologists know is that there are 1,000 scans requested from your emergency department. They don't know how many patients that reflects. And so as our members were asking for comparative data, they didn't want the CDC utilization. They wanted the number of scans per 100 patients because that's what they were being handed to compare by radiology. Okay. All right, a couple of trend lines that pop out here. There's very good correlation between walk-away rates, so the left before treatment complete rates, with length of stay. And within any of those volume bands, I could break up those volume bands and show you there's a threshold in each of the volume bands that seems to reflect how long people are willing to tolerate stays in the emergency department before they walk away. This drives the kind of configurations that you're going to do. It drives decisions that you'll make in regard to how you staff. The basic unit of service is patients seen per day. And then how do you explain this to your staff? Well, you explain it by saying, how many times do we do this procedure? How many patients do we see with these following complaints? What kind of service did we deliver? What was the disposition? And so this piece of paper for your emergency department is a good way to make all these statistics come to life. And then the comparisons allow you to go and talk to the other specialty groups or the lab leader or the person who's responsible for reading EKGs to know that you're well within the volume band. For solutions, we need to look at intake throughput and disposition and go through Clockwork ED, look through the ACS model that I talked about before, begin to build these programs of building ahead. And then finding solutions results in us skillfully using that data to go do everything from what Rick described to you, go make a financial argument to your CEO, through to talking to radiology, through to talking to the insurance companies who want to come and beat you up. In my opinion, the 20 numbers you need to manage your ED then reflect very much the numbers that I showed you already, and the list is in your book. It's patients per day, down through the various admission statistics, and down through, and what we didn't compare is patient satisfaction scores and financial outcomes, because that's still sensitive data for our member hospitals. But this gives you the 20 data elements that you need to manage your emergency department. So go home. If you're interested, people who submit their data then get our data report, which is about a 50-page report analyzing the various cohorts and elements of what we do. It gives you a good thing to go to your CEO, CFO with and allow you to have some hard numbers to compare with. And then finally, it begins to teach you how to put a plan together that says 5 years from now, what's our ED going to look like? 10 years from now, what's our ED going to look like? And 20 years from now, are we prepared to deal with the populations that we'll have to deal with? Sorry, I went a couple minutes over. Do you want to say any parting comments?
So you have to subscribe to that, or you can't just give out the internet, right?
No. It's
What's the cost?
the cost for joining the Emergency Department Benchmark Alliance is about $1,000. And we don't offer this. It's not intended to be a fee-for-service set of numbers. So, all right, thank you for the opportunity.